Hi, thanks for joining me. This is Max Marino, PGY-IV. I'm going to be talking about the medical and surgical treatment of intracerebral hemorrhage. I have no disclosures or conflicts of interest, and I just wanted to mention that my goal is to provide multimodal resources for the practitioner to use in their approach to patient care and dispel any misunderstandings or bias due to cultural norms, language barriers, or personal beliefs. So let's jump right into it. Current management of a critically ill neurosurgical patient is largely performed in a multidisciplinary setting by a team including critical care specialists, neurologists, and neurosurgeons. Beyond the neurological consequences of ICH, patients are susceptible to systemic complications such as DVT, pulmonary embolism, pneumonia, cardiac pathology, urinary tract infections, and skin breakdown. As a result, a comprehensive approach must be taken to the care of this complicated patient population. And hence, the AHA recommends that initial monitoring and management of patients with ICH should take place in an intensive care unit or dedicated stroke unit with physician and nursing neuroscience acute care expertise. Initial medical management after the standard principles of critical care have been implemented, like your ABCs, are to control systemic hypertension and correct any coagulopathy. Controlling intracranial pressure and preventing hematoma expansion follow. The AHA guidelines include consideration of early CT angiography to assess for a spot sign, which is active extravasation of contrast agent within hematoma. On this drawing, we can see an example of it right here, a little spot sign within the hematoma. A spot sign is of limited relevance after the bleeding has stabilized on repeat CT scan. Neuroimaging to prove stability at a 6-hour interval and identify potential causes should be completed. Characteristics that increase the likelihood of finding a vascular cause include being of female sex, a lobar ICH in a patient younger than 65 years, a primary IVH without ICH, and no history of hypertension, smoking, or coagulopathy. Yet, there is no sex, age, or history alone that will exclude a vascular or tumor-related cause without proper vascular imaging. In younger patients, and whenever invasive interventions may be planned, it is prudent to always perform vascular imaging with at least a CTA. MR angiography alone may be less sensitive to vascular causes in the setting of ICH, but MRI may reveal tumors or infarcts as the cause of ICH and is useful in late follow-up after the blood is cleared, identifying underlying cavernous angioma. Catheter cerebral angiography should be undertaken in cases in which clinical suspicion is high, like a young non-hypertensive patient, if there's associated subarachnoid hemorrhage or suspicious finding on CTA or MR. Venous thrombosis should also be considered as a potential cause of ICH, particularly in cases of patchy lobar ICH and those associated with potential venous infarct. It can be evaluated with CT or MR venography, or MRV. Here's a list of trials which will be mentioned heretofore that concern the medical treatment of ICH. So you can familiarize yourself with these, Google them, look them up, find the PDFs for them. They more or less describe what the intervention is, whether it's blood pressure control, correction of a coagulopathy, for example, at the very bottom there, TXA administration, and whether these are effective measures, what the primary endpoints are, and any limitations in those measures. So here's a question. We have a 40-year-old woman who has an acute onset of left hemiplegia. She is alert, answers questions, and follows commands. CT scan is shown. Her pulse is 80. Her A-line shows a 210 over 110 blood pressure. Which of the following is the most appropriate next steps in the management of this patient? Rafia, why don't you give this one a shot? Correct. I knew you'd get this one. It's an acute blood pressure control with SPP goal to 140. This is per the AHA 2015 guidelines. For an ICH patient presenting with a systolic blood pressure between 150 and 220 and without any contraindication to acute BP treatment, the acute lowering of the systolic to 140 is safe. This is class 1 level A evidence, and it can be effective for improving functional outcome. For patients who have a systolic greater than 220, it may be reasonable to consider aggressive reduction of blood pressure with a continuous IV infusion and frequent blood pressure monitoring. Elevated blood pressure is very common in acute ICH because of a variety of factors, including stress, pain, increased intracranial pressure, and other morbidities. So high systolic is associated with greater hematoma expansion, neurologic deterioration, and death. So blood pressure control is very important early on. At admission, hypertension is associated with worse outcomes and a systolic blood pressure above 140 to 150 after ICH has been shown to double the risk of subsequent death or dependency. Although the need to manage hypertension in the period immediately after the bleeding episode is well established, the target blood pressure remains controversial. The Interact trial was a randomized trial with 203 patients to a low target of systolic 140, which was achieved within 1 hour and maintained for at least 24 hours after hemorrhage. The other arm of the trial was 201 patients randomized to a systolic of 180. Patients treated with aggressive lowering of blood pressure did not have a higher mortality, rate of dependency, or cardiovascular morbidity. There was also a trend toward reduced hematoma expansion within the first 6 hours after ICH. Interact 2 was a larger study that also did not find a difference with aggressive control for death or major disability, the primary outcomes. An analysis showed that improved outcomes in the treatment group and superior quality of life. There were no differences when assessing hematoma growth or in the adverse events resulting from aggressive control. But then you had the ATACH, which is the antihypertensive treatment of acute cerebral hemorrhage, and the ATACH-2 trials. They evaluated the use of nicardipine to lower blood pressure in hypertensive ICH. In ATACH-2, patients were randomized to intensive treatment, which was a target of systolic 110 to 139, or a standard treatment, which was systolic 140 to 179. The trial was stopped early because of a significantly increased rate of renal adverse events within 7 days of the randomization in patients in the intensive treatment group, the ones that were having the lower blood pressure. Also, lowering systolic from 110 to 139 did not improve mortality or disability rates at 3 months compared with the standard treatment. A sub-analysis of the group of patients who achieved systolic less than 140 within 24 hours showed a higher rate of neurological deterioration and cardiac adverse events. So currently AHA or ASA guidelines recommend that for patients with an ICH with a systolic between 150 and 220 and without contraindication to acute blood pressure treatment, lowering of systolic to 140 is safe and may improve functional outcome. Patients with ICH greater than 220, it may be reasonable to consider aggressive reduction of blood pressure with a continuous IV infusion and frequent blood pressure monitoring. ICH occurs in the background of other medical comorbidities, including renal and cardiac diseases and underlying cerebrovascular occlusive disease. Blood pressure should be managed with these variables in mind. Blood glucose control. Although there are limited data pertaining to the optimal blood glucose level for patients with ICH, it is known that hyperglycemia is detrimental in this patient population. Hyperglycemia in animal models of ICH results in more profound cerebral edema and increased perihematoma cell death. Clinical studies appear to confirm the deleterious effects of hyperglycemia in patients with a previous diagnosis of diabetes mellitus and those with acute hyperglycemia. The AHA and ASA guidelines state that glucose should be monitored. Both hyperglycemia and hypoglycemia should be avoided. Kimura and colleagues prospectively studied the admission blood glucose in 100 patients with spontaneous supratentorial ICH. Patients were evaluated over the course of 2 weeks and divided into patients who died within 14 days and those who survived. The median admission glucose in the death group was 205, that's mg per deciliter, versus 131 in the survivors. Further statistical analysis found an admission blood glucose level of 150 to be the cutoff value for predicting early death. Kazui and colleagues found a fasting plasma glucose level of 141 or higher combined with the systolic of 200 or higher to be independently increase the risk of hematoma expansion. Other studies showed and evaluated the effect of diabetes and admission hyperglycemia on outcomes and neurological and systemic complications in patients with ICH. In the case of coma patients, diabetes and hyperglycemia did not play a significant role in determining outcomes because the majority of patients died. However, diabetes was an independent predictor of 30-day and 3-month mortality in non-comatose patients. Patients with diabetes also had a greater incidence of infectious and cerebral complications. Patients without diabetes with hyperglycemia also had poorer outcomes and a greater incidence of cerebral complications. Data also suggests that aggressive glucose management with an insulin infusion can lead to a low cerebral extracellular glucose concentration. A study concluded that systemic glucose levels should not be treated acutely in the setting of ICH unless they exceed 180. Temperature management. Fever can occur commonly after an ICH and IVH. The duration of fever is related to outcome and appears to be an independent prognostic factor in patients with ICH. Maintenance of normothermia has been clearly demonstrated as beneficial to outcome. AHA and ASA guidelines were updated in 2015 to include that treatment of fever after ICH may be reasonable. However, treatment with hypothermia, lowering their temperature, should be considered investigational in ICH. Systemic anticoagulation. Bear with me because this is a big one, and there's going to be a lot of questions on the test about this one, or at least the possibility of those questions, because they can ask about anything from warfarin to NOACs to DOACs and how you would reverse each of these. The prevention of a hematoma expansion and the urgent need to minimize the size of the clot are primary goals of emergent ICH management. Once the diagnosis of ICH is confirmed, blood pressure control and normalization of the coag profile should be aggressively initiated. These goals hold true even in patients on systemic anticoagulation for thrombotic conditions with a risk of ischemic complications. Vitamin K antagonists, warfarin being the most common, are associated with approximately 20% of spontaneous ICHs, with a reported mortality rate as high as 67%. An INR higher than 3 is associated with larger hematoma volumes, a greater incidence of hematoma expansion, and poor neurologic outcomes. Multiple agents are currently used in the reversal of warfarin-induced coagulopathy. FFP and vitamin K historically had the most widespread use. FFP effectiveness is limited by the fact that it must be thawed and requires blood typing before use, thus causing critical delays in the early period of hematoma expansion. It has been shown that for every 30-minute delay in FFP transfusion, there's a 20% reduction in the probability of a successful correction of the INR at 24 hours. In addition, large volumes may be required to achieve a clinically significant effect, thereby leading to volume overload, heart failure, transfusion-related acute lung injury. Intravenous vitamin K has a slow onset, takes approximately 6 hours to achieve therapeutic effect. Current guidelines on the management of ICH from AHA and ASA recommend replacement of vitamin K dependent factors along with IV vitamin K. Furthermore, the recommendations support the use of prothrombin complex concentrate, PCC, as an option for rapidly reversing warfarin-induced coagulopathy. These commercially available products are concentrated mixtures of non-activated vitamin K-dependent clotting factors. 4-factor PCC contains high concentrations of factors 2, 7, 9, and 10, whereas 3-factor PCC doesn't have factor 7. Several studies have shown that PCC normalizes the INR within minutes in patients taking warfarin. However, the use and advantage of PCC over FFP and vitamin K have not resulted in a clear improvement in patient outcomes. There are large randomized controlled trials that have demonstrated the non-inferiority of PCC to FFP for reversal of INR that's less than 1.3 within 30 minutes. That's getting it to less than 1.3 within 30 minutes. The rate of thromboembolic events were similar in these groups. Direct thrombin antagonists and factor Xa inhibitors are being used increasingly as an alternative to warfarin for specific conditions. These medications do not require routine monitoring with lab tests and have fewer interactions with drugs and food. However, they unfortunately have limited pharmacologic means of reversal. Early studies, including RELY, randomized evaluation of long-term anticoag therapy with dabigatran, ROCKET-AF, which is a study for rivaroxaban, and Aristotle, which is the apixaban study, found that these agents to be associated with a lower incidence of intracranial hemorrhage when compared with warfarin. However, when bleeding does occur, particularly in emergent situations, no clear consensus has been reached. AHA-ASA guidelines recommend that PCC or recombinant factor 7A might be considered on an individual basis. Activated charcoal can even be used if the most recent oral dose was taken less than 2 hours beforehand to bind and prevent its absorption. More recently, reversal agents for the novel oral anticoagulants, NOACs, have been developed. Factor Xa inhibitors can be reversed with the use of a recombinant modified version of factor 10 that acts as decoy receptors and frees the endogenous factor Xa to activate clotting. And Dexanet alpha was approved in the United States in 2018 as an antidote to rivaroxaban and apixaban. The reversal of dabigatran, a reversal inhibitor of factor 2A, which is thrombin, can be achieved with idarosuzumab, a monoclonal antibody that binds dabigatran and its metabolites. These reversal agents have been tested for reversal efficacy in several phase 3 studies, and the use in ICH specifically and its effects on clinical outcomes will require further study and wider availability of these medicines. Adequate reversal of novel anticoagulant effects can be reliably achieved with hemodialysis. but this is often impractical in the most emergent settings, causes potentially life-threatening delays. Finally, we've got our antiplatelet agents. Aspirin is associated with an absolute risk of increase of ICH of 12 events per 10,000 people, a risk that grows even higher in the elderly population. With the evolution of endovascular technology and techniques, a growing number of patients are maintained on long-term dual antiplatelet therapy, primarily aspirin and clopidogrel, for coronary and carotid stents, intracranial stents, and flow diverting stents. Preclinical and clinical trials have shown dual aspirin and clopidogrel therapy to exhibit significant synergistic effects, resulting in increased platelet inhibition and bleeding risk. As a result, these agents have also been found to be an independent predictor of hematoma expansion. Both aspirin and Plavix irreversibly inhibit platelet aggregation. Aspirin inhibits platelet function for the 7 to 10 day lifespan of the platelet. With the discontinuation of clopidogrel, Plavix, platelet function begins to recover after 3 to 5 days, and complete restoration of function is achieved at 7 or 8 days. So obviously, in the setting of an acute ICH, discontinuing antiplatelet therapy alone, it may not affect the hematoma expansion. The PATCH trial, a randomized open-label phase 3 trial, investigated functional outcome or death at 3 months and found no benefit and a possible signal of harm by attempting to reverse antiplatelets. In the setting of operative intervention or EVD placement, the usefulness of a platelet transfusion is not well studied. One study showed that in aspirin-sensitive patients on aspirin with ICH who received a platelet transfusion had less frequent postoperative hemorrhages and improved outcomes. Most surgeons will administer platelets before EVD placement or if there's an operation, and in cases with demonstrated expanding hematomas in patients who are on clopidogrel. However, there's no consensus regarding the volume of platelets required to effectively reverse aspirin and clopidogrel. So here we got a question. There's 6 of these questions. They're going to be the same 55-year-old man, but he's on a different agent each time. So this time it's 55-year-old man on clopidogrel. He's transferred to the ED, he has ICH, and requires immediate evacuation. Which of the following is the best strategy for management of this patient's coagulopathy? All right, how about Alice? You take this one. Excellent. I knew you'd get this one. Intravenous administration of 0.4 mics per kg of desmopressin, followed by a plate transfusion. I know we talked a little bit about being controversial. There's no specific reversal agent for clopidogrel. It's recommended that patients receive some desmopressin intravenously, followed by platelets. DDAVP acts by increasing plasma von Willebrand factor, factor 8, and intracellular platelet calcium-sodium ion concentrations, and increases the formation of procoagulant platelets and platelet adhesion to collagen. The other answers are incorrect. There'll be reversal agents for some of the others. So this same 55-year-old guy, he's on abciximab. For this one, you have a number of different choices for reversal to manage his coagulopathy. How about Imran? Nice. Perform platelet transfusion of 2 to 2,600 mils and proceed to the operating room. Abciximab binds to the glycoprotein GP2B3A receptor of human platelets and inhibits platelet aggregation. So platelet administration will be most effective strategy for treating the resulting coagulopathy. All of the other agents here don't have a role in this case. So now you've got a guy who's 55 and he's on warfarin for AFib. He also has an INR of 4.0. So which of the following is the best strategy for management of this patient's coagulopathy? Paras, I know you got this one. Correct. It is B. IV administration of vitamin K, 5 milligrams, and the 4-factor PCC, and proceed to the operating room. So it's easy. Optimal reversal strategy is to administer 4-factor PCC immediately given it has a rapid effect, especially when immediate surgery is required, and concurrent administration of vitamin K to replenish the clotting factors inhibited by warfarin. All right, same guy, apixaban. Let's see. What do you got, Ty? Tell me what you think. Yeah, that's right. It's an IV bolus of 800 milligrams andexanet alpha, followed by infusion of 8 milligrams per minute for 120 minutes. Apixaban is a factor 10A inhibitor, and it's recommended for the prevention of stroke and systemic embolism in those who have non-valvular AFib, and then other stroke risks. Andexanet alpha is a recombinant modified human factor 10A protein that will bind directly to free-floating factor 10A inhibitors and sequester them, thus rapidly reducing their free plasma concentration. All right, same guy. Now he's on rivaroxaban. How about aerial? Yeah, you're right. It's the same thing. Rivaroxaban and the one before, apixaban, they work similarly. It's a DOAC or NOAC. They can be reversed or at least inhibited with andexanet alpha. All right, now this guy's on dabigatran. What are you going to do before you take him to the OR? How about James Braz-Jonas? Cool. Yeah, you knew this one. It was IV administration of 5 grams idaracizumab. I think Pradaxa is the name of dabigatran. So this is also known as Praxbind. It's a humanized antibody fragment against the thrombin binding site of Pradaxa. So nice. Those aren't so bad. You do want to also monitor intracranial pressure. Large hematomas, especially those associated with IVH and obstructive hydrocephalus, are frequently associated with elevated ICP. Medical management of ICP includes systemic cooling, sedation, diuretics, and the administration of paralytics. You want to treat hydrocephalus with the insertion of an EVD, which is a level B recommendation per AHA-SA guidelines, and patients should have all coagulopathies corrected before inserting to prevent hemorrhagic complications of the procedure. If ICPs were factored in medical therapy, surgical decompression should be considered. It's notable that steroids have no role in elevated ICP or in ICH. Anti-epileptic medications. Seizures associated with ICH may be non-convulsive, hence the true incidence is likely underreported. One study with their colleagues found seizures to be rarely associated with spontaneous ICH. At 30 days follow-up, 8% of patients had seizures. Lobar hemorrhage, most likely caused by close proximity to the cortical surface, was significantly associated with the occurrence of early seizures. The AHA-SA guidelines state that seizures that are uncontrolled lead to elevated ICP and elevated blood pressure and require IV anti-epileptic therapy. You should treat clinical seizures with anti-seizure drugs. Patients with a change in mental status who are found to have electrographic seizures on EEG should be treated with anti-seizure drugs, and continuous EEG monitoring is probably indicated in patients with ICH with depressed mental status that's out of proportion to the degree of brain activity. Prophylactic anti-seizure medication is not recommended. All right, we got a patient with what's the most? We don't have a patient actually. It's which of the following is the most effective means of treating symptomatic increased ICP resulting from intracerebral hematoma? How about Stacy? Right. Actually, it is the evacuation of mass lesion. Correct. For ICH due to mass lesion, it's surgical evacuation. Sedation, paralytics, and hypertonic therapy may be used in the setting of elevated ICP without a mass lesion, and steroids are not indicated. All right, here we have a surgical hematoma. We're going to talk about the surgical management. Surgical hematoma evacuation remains actively studied area given the successful results in protocoled case series. Identifying patients who will benefit from evacuation has been the subject of multiple investigations and recent results of minimally invasive surgery plus TPA for ICH evacuation and the CLEAR trials, which have identified a threshold of evacuation and may be vital to affect functional outcome of ICH. To date, no robust study has shown the benefit from surgical intervention. However, in properly selected patients who reach the defined threshold of hematoma evacuation, there is strong indication of improved functional outcome after ICH. Evacuating surgically has been associated with a decreased 30-day mortality rate, but any potential improvement in functional outcome has not been convincingly demonstrated. This is in part due to the concurrent advancement in ICH medical management. Emergent hematoma evacuation remains a life-saving intervention in younger patients with large ICH volumes who are deteriorating clinically and in patients with cerebellar ICH. Here we see on the top, this person had an evacuation with a craniectomy. You can see a little bit kind of the hardware they had back there. This patient has placement of a drain that drained the ICH. It's important to mention the STITCH trial. This was a comparative study of early surgery with initial conservative treatment in patients with spontaneous supratentorial ICH. Divided patients into either an early surgery group that combined hematoma evacuation within 24 hours of randomization and medical management, or a group that received medical treatment only. The outcomes were GOS at 6 months, which was the primary measure. A good outcome in the good prognosis group was defined as a good recovery or a moderate disability. This study, which included data from over 1,000 patients, consists of 2 relatively well-matched groups randomized to surgery or initial conservative management. There was no significant difference in the percentage of patients achieving a favorable outcome at 6 months, and the mortality rates between both groups differed by only 1%. Of patients initially randomized to medical treatment, 26% eventually received surgical hematoma evacuation. The conclusion here was that there was no overall benefit of early surgery compared with initial conservative treatment in patients with spontaneous supratentorial ICH. However, we had stage 2, which was the trial for lobar intracerebral hemorrhage without intraventricular hemorrhage. This was a prospective randomized trial, over 580 patients with lobar ICH without IVH and hematomas that were anywhere from 10 to 100 cc's. They also had a GCS score of 5 or greater. The 2 groups was an early surgery group, hematoma evacuation within 12 hours of randomization plus medical management, and conservative treatment group, which is just medical treatment alone. The outcomes was the extended Glasgow outcome scale at 6 months. Secondary outcome was mortality. So there was no significant difference in favorable outcome between early surgery and medical treatment, and similar mortality rates between early surgery and medical treatment. There was a trend toward improved survival in the early surgery group, and 20% of medically treated patients underwent surgery in a delayed fashion and had worse neurological outcomes at the time of surgery. The conclusion was that early surgery for lobar ICH without IVH and hematomas of those sizes does not lead to increased rates of death and disability at 6 months and may confer a survival advantage. However, further research is needed. There are different approaches to ICH that are emerging and have been emerging for some time, like endoscopic and minimally invasive evacuations. One argument against conventional open surgery for ICH is that the approach to the hematoma may result in additional damage to otherwise unaffected brain. Multiple studies have evaluated the usefulness of endoscopic evacuation as an option. Subgroup analysis of these different patients will vary based on their consciousness level, age, location, size, and the site of the hematoma. One particular study showed that with 50% clot removal, that 15% of patients having over 90% of the hematoma evacuated. In the overall analysis, these patients were treated with endoscopic evacuation and achieved better outcome than those in the medically treated group. Endoscopic, there's 4 studies listed on this page. They're all pretty good. The conclusion here was that endoscopic evacuation is a safe and effective procedure for ICH that may lead to decreased mortality and improved functional recovery in carefully selected patients. Which of the following is the most appropriate first-line therapy for a cerebral venous sinus thrombosis with ICH? For this one, how about Saman? Good. Yeah, it's anticoagulation. According to the AHA guidelines, the first-line treatment of a cerebral venous sinus thrombosis is anticoagulation. Even though there's an associated ICH, it's important to take care of the venous sinus thrombosis, since that's what might have caused the ICH in the first place. Decompressive hemicranie. This is a good picture or a video. Unfortunately, it looks like it was blocked, but if you Google decompressive hemicranie for ICH, you'll find plenty of good videos. And I was going to show one, but we're also running out of time. Here's another question. Evidence showed that there's improved outcome of surgical evacuation of a 3 centimeter spontaneous IPH causing neurologic deficits when it's performed in which of the following locations? Chip, I know you know this one. Nice. It is the cerebellum. Posterior fossa has very little room to spare, and due to a small space and adjacent eloquent structures, a hemorrhage can cause rapid and devastating consequences. So it is indicated for a clot greater than 3 centimeters in diameter, or patients whom cerebellar hemorrhage is associated with brainstem compression or hydrocephalus. They may have better outcomes with a urgent decompression. And that for that reason, that is the management of cerebellar hematomas. It's recommended that all hematomas greater than 3 centimeters in diameter or can be considered for smaller hematomas in awake and alert patients with close clinical observation. You can do a ventriculostomy for small hemorrhages that are adjacent to the fourth ventricle, in which hydrocephalus is a risk or is developing. There's also the management of IVH. We know from the CLEAR trial that IVH, you can use intraventricular thrombolytic agents to prevent EVD obstruction and enhance the clearance of IVH, and it's been widely reported. There have been several trials in the CLEAR program, and some people even had 2 or more catheters placed, which can improve the management of this condition affecting ICP and cerebral perfusion pressure. Higher volume of clot removal should be aggressively pursued in order to achieve the functional benefits of the procedure. The AHA-ASA guidelines state that although intraventricular administration of TPA in IVH appears to have a fairly low complication rate, the efficacy and safety of this treatment are uncertain at this time, so that's important to know. As far as OMT goes, I know a group of people who published a paper about osteopathic manipulative treatment on the glial lymphatics of patients with TBI. The TBI pathophysiology has been historically poorly understood, but new evidence on TBI pathophysiology, molecular biology, and diagnostic studies has emerged. The goal of this study was to assess the effects of OMT on peripheral and central glial lymphatics in TBI patients with brain edema and elevated ICP. This was a retrospective study done at a level 2 trauma center in 2018, and the patients enrolled had TBI, increased ICP, or brain edema, and had an EVD placed. Some of these included patients with ICH. Patients received 51 minutes of OMT to the head, neck, and peripheral lymphatics, and the outcomes or the results were ICP, CSF drainage, optic nerve sheath diameter, and NPI were recorded before, during, after OMT. The conclusions here was OMT may help optimize glial lymphatic clearance of CSF and improve brain edema. A holistic approach, including OMT, may be considered to enhance the management in patients like this, and that includes patients with ICH. The results can better inform future trials to study the effectiveness of OMT in patients who have either for post-concussive treatment, mild to moderate TBI, supratentorial ICH, and so on. For further reading, these are where the guidelines, most of them you're going to find, are here. Neurocritical Care, Journal of Neurocritical Care has the guidelines, as well as Stroke has the guidelines that are the AHA-ASA guidelines for management of ICH. And these are my references. Thanks, everybody. I hope you had a good time. I really miss you. I'll see you later.